All right, guys, we'll get started. We're at Point today with Alabama EMS Challenge. Thanks Centerpoint for hosting us as always. Thanks Chief Ward for running the show. We got guest speakers. We got Dr. Amy Rose, UAB ER resident, and also Dr. Briana Miller. We're going to talk a few minutes about just things going on in the region, and then we'll break into sepsis, and after that, renal emergencies. So thanks for smiling, and thanks for showing up today, sir. Good. All right. So remember, EMS Challenge was started back in 2014 to improve Con Ed for the region. We're seeing about 150 plus people per class now online, so really appreciate the participation. Hopefully with our new BRIMS building, we can start doing some of these in downtown Birmingham, have a little more space. But we are accepting folks to come into the class, so you can come in person. We are socially distancing, okay? For your certificate today, you can follow the instructions in the chat box for your certificate. You can also email alabamaemschallenge@gmail.com. If you can do that, do it before 2 o'clock today so we'll get that stuff back out to you. Everything we do send out is approved by the state. Educational updates, we'll be in Oxford at the Oxford Civic Center on the September 22nd. We're going to talk about 12 leads and some cardiac cases, and I believe it's going to be chest trauma. And then from 12:30 to 2:30, we'll have a skills lab. We'll do pig crew CPR. We'll do advanced airway techniques, and then we'll have some pig tracheas, do some surgical airways as well. No need to sign up in advance. Just show up. It'll be from 9 to 11 lectures, and 12:30 to 2:30 is a skills lab. We'll be at the Fire College in October. That's the 4th Wednesday. We'll still be here the 2nd Wednesday, but the Fire College in October, the 4th Wednesday. Same setup, lectures 9 to 11, then skills lab 12:30 to 2:30. Don't forget our state EMS conference is November 1st through 4th, I believe, at Orange Beach. The SMEC meeting will be November 2nd. It's that Tuesday. We have not had one in about a year and a half due to COVID, so please, if you're interested, show up for that. It's an open forum. It's 2 o'clock that Tuesday, I do believe. We'll also be down at the Volunteer Firefighter Organizations Conference the following week, the new EMS Challenge. More information on that will follow up. And then don't forget, I think Mr. Miner sent out an email, BRIMS, we are now moved. We're on 10th Avenue or 10th Street South, I believe. The location is on our webpage, but come out, take a look, see what we got. We got a lot of new conference room space. We should be up and going full swing here in a couple of weeks as well. So let's talk a little about ketamine. There was some stuff published on EMS1, EMS Today, and then some of the news media is about the case in Colorado from 2019. Just some things to think about. You know, ketamine in our protocols was put in for altered mental status, but remember, it's really more for something else, right? So what is ketamine? All right, ketamine is a sedative. It blocks glutamate, which excites cells. So the goal of ketamine is to chillax people, to make them calm where you can manage them, all right? There are some risks to ketamine. Most of the risk would be from over sedation. When you think about the literature, ketamine is relatively safe in the hospitals for sedation and so forth, but we also know our patients at that point in the game. The patients we take care of in the field have been smoking some weed, maybe some cocaine, drinking some alcohol, have a lot of drugs on board, and even a little bit of ketamine can put them over the edge and cause respiratory problems. So we got to be very careful with ketamine, okay? So what do we use it for? We use it for excited delirium or agitated delirium, okay? Our protocol state we can use it for altered mental status or pain control. My advice, stay away from it from pain. This is all you got, okay? And if you do, make sure you dose it appropriately. It should be used for the agitated, combative person who you cannot manage otherwise safely, okay? It is for the person who is butt naked, trying to beat you up and fight with the police or fight with you, all right? No, they do not. Yes, sir. Yeah. So this patient, 6-foot male in a nursing home, when approached, he kind of screams, claws at the staff. He doesn't walk at baseline though. He's diaphoretic. He's confused. He's got cloud of urine in his Foley bag. He's got a history of similar events in the past. This guy meets the definition of altered mental status. He's a little bit combative. Does he get ketamine? No, very good, good from command staff. I like that. Good. Thank you for keeping up. Yeah, this guy does not get ketamine, right? This guy does not need ketamine. You give this guy ketamine, you can have a bad outcome. This is a 6-foot male. He's acutely psychotic. He's kind of screams and claws at the police, diaphoretic. He appears to be responding to internal stimuli, talking to himself. All right, we've got a history of similar events in the past. This guy, is he appropriate for ketamine use? Yes, very good, good. Thanks for paying attention, Chief. Appreciate you, yeah. All right, good, good. So what's going on? When you think of excited delirium, there are a lot of causes for this. So remember, anybody that has excited delirium, even post-ketamine patient, we got to determine what's going on with them. Usually we see this with acute psychosis, patient with underlying psychiatric disorders who is off their medications or has some new distressor. It could be alcohol or drug induced. It could be hypoglycemia. The good thing about hypoglycemia is they eventually pass out completely. They don't need drugs. And then you check a glucose and you can fix them, right? But cocaine, spice, meth, lots of things can cause this. The problem with excited delirium is that it can go on and lead to cardiac arrest. They can have a rhabdo. They can get hyperkalemic. They have all kinds of issues. So we do need to treat these patients, but we need to be wise when we're using our ketamine. Remember, ketamine is based on ideal body weight, okay? So of the two pictures, right? Height is what matters, not actual weight. All right, so a 5', 6' male who's 300 pounds, weighs 160 kilograms of ketamine, 160 kilograms. What's the dose of ketamine for this guy for excited delirium? What's our protocol say? Anybody know? Sir?
Ideal body weight.
Now, he weighs 160, but that's not his ideal body weight, correct? What's the dose of ketamine, you know?
That's what you're giving it.
So excited delirium, he's agitated, he's beating up people, he's confused, diaphoretic. Yeah, 2 to 4 mg per kilo, right? So if we're doing 2 to 4 mg per kilo at 160, that's a big dose, right? Yeah, that's a big dose. So what I kind of do is I think ideal body weight. There's a lot of formulas out there you can calculate, been around for years, kind of confusing. So I kind of have my own formula. And basically what I say is 52 kilograms for males at 5 foot and 2 kilograms per inch, or 50 kilos at 5 foot for females and 2 kilograms per inch. All right, you got to do some math, but I kind of think of ideal body weight as the Braslow tape for adults. Okay, so the easier way to do this is figure out what dose you would get for ketamine if you were going crazy and fighting somebody. All right, and that way you can refer your height to the patient's height and calculate the dose a little bit better. All right, so if this guy was 5'6", 350 pounds, that's 160 kilograms. If he got 4 mg per kilo of ketamine, that's about 640 milligrams. That is way too much. His ideal body weight based upon the 52 is 62 kilograms. So he gets about 250 milligrams. So you see it's a big difference. So I recommend either have a way to calculate ideal body weight or just cut the dose in half of the ketamine. All right, you got to be safe with that. If you want to be non-gender, you can just say 50 kilograms at 5 foot and 2 kilograms per inch. It's a rough estimate. You better underdose than overdose these people. But the other key point is post-ketamine patients are critical patients. Once they get ketamine, all right, for their excited delirium, once they're calm and it's safe to approach at that point in the game, you expose them, you cut their clothes off, you look for life threats, you look for patches, fentanyl patches, things like that. You look for holes for trauma. You get a glucose, they get put on the monitor, the SpO2, they get put on the EKG monitor, they get put on the blood pressure cuff. If you have capnography, they get that as well, okay? These guys also have to be transported to an ER. There's no way you give ketamine for excited delirium and this patient goes to jail, okay? Once you give the ketamine, they're a critical patient, you assume control of the patient, you figure out what's going on, you look for life threats, you monitor them. If they get hypoxic, they do not get O2. They get simple airway maneuvers. They get jaw thrust. They get an OPA or nasal trumpet. If that fixes the problem, great. High five your partner, call it a good day, move to the hospital as you're looking for while they were excited and agitated. If that does not fix the problem, at that point they get oxygen and they get a BVM and you ventilate them. If they lose their airway reflexes, you can intubate them. That is reasonable, okay? What you cannot do is just put O2 on somebody post-ketamine because they get hypoxic because they're not breathing. Okay, you're going to cause problems with that. So remember, ketamine, reasonable drug to use for excited delirium. Okay, it helps people, keeps them going to cardiac arrest for excited delirium. But once you give it, you got to manage that patient and be safe with it. Cool. That's all I got, and we'll switch over to Dr. Rose. Remember, the goal of ketamine is not to make them not breathe and not move. The goal is to get them where we can manage them, take them to the hospital. All right. Right? And the goal is not to kill people. So thank you for smiling. Good. All right. Dr. Rose. Chief, how do I switch this over?
Hit escape.
For you, ma'am?
Thanks, so.
No, thank you.
All right. So Dr. Rose, I actually forgot to update the slides, so I'm actually PGY3 now. So everybody should congratulate me when you see me. Maybe I'm still a PGY2. All right, so we're going to talk about sepsis. I don't have any disclaimers. So we're going to talk about what is sepsis, how to recognize it, and kind of how you can help us out, you know, when you're dropping these patients off in order to give them the best chance at a good outcome. So you hear sepsis all the time, and, you know, most people are like, okay, there's sepsis, but what does that have to do with me? And then, you know, it affects a lot of people, and especially people that you guys are bringing in. So I'm hoping that with this talk, we'll be able to kind of recognize how you guys can, you know, do the best for the patient. And what that means is recognizing kind of the same things that we do when you drop somebody off. And what we use in the ED is we use SIRS criteria. So you've probably heard that before. I know I talked about this previously last year, and a lot of the EDs are using SIRS criteria because it's tied to CMS, which is important to keep our lights on. So what is it? So, you know, you're looking at temperature less than 36 centigrade, more than 38, but this is America. So we're looking at 96.8 degrees of Fahrenheit, or your 100.4. So if somebody comes in and they're 100, the first question I would ask is, have you taken any Tylenol or ibuprofen recently? Because that's going to obviously affect, you know, how you interpret it. And if they haven't, they don't actually technically meet a temp yet, something to be aware of. Heart rate above 90, respiratory rate above 20, and then white count plus some other things. But you don't really have to care about that because that's not anything that you're going to get in the back of the unit. So like, unless running CBCs is a new thing, which I don't think it is, you can get most of this from just like checking a set of vitals. Some places have started to switch over to the QSOFA, and essentially what that is it's respiratory rate, are they having any kinds of altered mental status, and what's their blood pressure doing? Because we're still kind of tied to CMS, and, you know, a lot of the patients that come through are Medicaid, Medicare, we're still using SIRS criteria. So what is it? So you've got SIRS, and then you add a little sprinkle of infection on there, and then you've got sepsis. When you've got sepsis, plus you've got some kind of end organ dysfunction, so this is kind of tying into why they use blood pressure with QSOFA. So if you're having like some kind of systolics of 89, you've got a creatinine bump, a bili bump, any platelet issues, INR, lactic, these are things that you're not going to know. You're just still going to be recognizing, you know, is this sepsis or not, but what we look at. But when you've got signs that you're like, okay, now the liver is struggling, now the kidney is struggling, you know, they're not able to maintain their blood pressure. Well, now we're kind of rolling over to severe sepsis. And then when you've got the severe sepsis, you give them a bunch of fluids and they're still hypotensive after the 30 cc's per kilo. That's what we're doing. And just like Ferg was talking about ketamine, that 30 cc's per kilo is ideal body weight. So if you have somebody that's coming in and they're an Alabama unit and you calculate the 30 cc's per kilo and you're calculating like 6-7 liters, that's probably a red flag that there's probably something wrong. But starting, you know, a liter en route with transport is never a bad idea. Sometimes it is a bad idea. And then when we get our labs back and the lactic is above 4, well, that's when we're starting to think about septic shock. And, you know, these folks are really the ones that have poor outcomes. My first rotation back when, because you guys probably like saw me a couple of lectures last year, I was very pregnant. So, you know, I had my maternity leave, and they were kind enough to give me admin as the first one back, because that's stuff I can do at home. And part of my admin is doing sepsis chart reviews. And you don't realize it at the time. Ferg's laughing, so I probably emailed him like 50 times about his sepsis charts. You don't realize it at the time, but a lot of these patients who come in for septic shock, you admit them to the ICU, and I think I had like 13 charts to review, and only 4 of them like made it alive. I don't know if I just got the sprinkling of bad charts, but these people like decompensate real quick. So what's happening is, you know, like, well, why are we looking at lactic? You know, why is the blood pressure low? Why is the other organs? And the whole thing is that this is a demand and supply issue, right? So you've got, the body needs a certain amount of oxygen, it needs you to remove a certain amount of waste, and you're just not able to do it because the, you know, the heart isn't pumping as well. You've got, you know, mild cardiac depression, just leaky vessels, and we'll talk a bit more about this in a bit. And you're just not able to keep up. And, you know, you'll have, so say you'll have a marathon run and they're kind of running, if you were to check a lactic on those folks, you know, it'll be up on them just because you feel it when you haven't worked out in a while and you've got that burning in your muscles and you're like, what is this? And it's your little lactic bump that's going up. But these folks aren't able to compensate for it. They're not the marathon runner, you know, they're not the people with an immunocompetent system. So what happens is, so you've got this infectious trigger, and then your body is like, oh my gosh, like this is insane. And either they can't keep up with the infection goes ravenous. You start to get a little depression of your ejection fraction of your heart. Your vessels get a little bit damaged, and I like to think of it as the garden hose, and you've just put a bunch of holes in it, and now it's kind of leaking everywhere, and you know, now your blood pressure is low, and that's just kind of cycling everything else, and now your heart, your kidneys, your lungs, your livers are all like, what is going on? Here's your vessels. Took me a long time to do this. Please appreciate it. So I sure can. There you go. The red Cheerios. You're welcome, sir. I almost animated it, but it's too much. Too much. All right. So so the problem is that, you know, you've got a lot of these folks coming in, it's got high mortality. They're staying in the ICU a long time. They're staying in the hospital a long time. It's expensive as heck, many billions of dollars every single year. And this $32,000 is per ICU per day. So this isn't like for total length of stay. This is per ICU day is what they're getting charged. There's septicemia right at the top, quite expensive. And again, like I mentioned before, you know, we care about it obviously because it has like very poor outcomes for patients, but it's also important for funding as well, especially with us being like a huge urban center, academic center. The current guidelines from the Surviving Sepsis campaign. So in the first hour, they want us to get a lactic, get a set of blood cultures, and then start broad spectrum antibiotics. Within 3 hours, they want, if you've got somebody that has low blood pressure, they want the 30 cc's per kilo of ideal body weight. They want the pressures to be 65 if you have to start pressors. And then you've got to go back and reassess within those 3 hours. This is where you guys can help out, because especially when you have somebody on scene and say you've got Mima that's up on the 7th floor of the assisted living facility, and again, you know, Alabama unit, and it's going to take you a hot minute to get her down the stairs and, you know, transport her and get her to the ED. This can already be starting. So getting a head start is really going to help this patient out. And, you know, we talk about evidence-based medicine. So, you know, I updated this from last year to talk about the Clovers trial. This has been ongoing for a few years. When I was at Virginia Tech doing medical school, this was, they were starting to talk about adding that facility as a designated kind of research area, and UAB have just started it now. And what it is it's looking at, you've got these patients who they can't receive the 30 cc's per kilo. And talked about that in the past. So these patients who have like very poor EF, you know, the heart failure patients, the dialysis patients who can't like, you know, pee off any excess fluid, you know, liver patients whose protein is low and they just third space everything. So I was like, you know what? How about instead of helping with their hypotension, instead of giving them fluids, we just go straight to pressors? And that's really what this is about. So we've started at UAB now, the Clovis trial, which is a multi-center randomized non-blinded trial. Obviously, it's kind of hard to blind someone from getting pressors or a bag of fluid. Everybody will get a liter to begin with. So you have someone that's sepsis, everybody will get a liter. Doesn't matter what branch you're in. And then it's like I said, everyone goes, so yeah. And then you'll be on the liberal fluids arm. So that's when you're getting an additional 2 liters after that reassessment, or you're switching to early pressors with the goal of 65 to 75 for MAPS, not necessarily systolics. And then norepi is the pressor of choice here. Evidence-based medicine, vitamin C, thiamine, and hydrocortisone have all been studied. Poor studies, no evidence that they actually help. The reasoning behind the hydrocortisone is that, you know, your cortisol is your stress hormone. So when your cortisol is high, you know, your blood pressure is up. And there was some thought that, well, with the end organ dysfunction, if there's some kind of adrenal suppression, and then maybe giving them a little bit of steroids can help, but it hasn't really been shown. That's an article out of JAMA there, just explaining why it wasn't very helpful. Narcan, so that's been studied in the past as well. There was a Cochrane review which says maybe it helps blood pressure, but we haven't actually studied it in terms of like outcomes in mortality. So, you know, don't use it, like don't start Narcan in all your septic patients, that's weird. And then the big thing is, so you've got somebody, it's how to find, like how to recognize sepsis, like when should I be suspecting that someone could potentially be septic, what certain scenarios. So obviously if you've got somebody that has a fever and they're like, oh yeah, I've got a UTI, I feel it, then that's a no-brainer. But just kind of keeping it always on the differential for everybody that you see is important. And there he is. Did everybody get it? Did you see it? The biggest 3 causes of infection, so your urine. Also, I found out, I typed in Google, this is completely off topic, I typed in Where's Wally last night to Google, and it kept correcting me to Where's Waldo. So I guess Where's Waldo is the American one. And then, you know, I looked back in the history, apparently like Americans thought Wally was a terrible name and wouldn't resonate, so they changed it to Waldo.
Yeah, that's a fun fact.
Fun fact, less fun for me. All right, so yeah, UTIs, your pneumonias, and then never forget skin as well. So if you've got somebody that has infected like decubitus ulcers, like bites, cellulitis, always keep those on, you know, again, look at your patient every time. We talked about that before. All right, so we can talk about some cases. So you've got an 85-year-old, she's got, you know, the plethora of health issues. Here are her vitals. Should you be thinking about sepsis with her? Yeah, she's febrile. She's acting off. Altered mental status in an older person. Just could be anything. Thing that you have to notice though is that you're like, huh, her heart rate's 89, but in these old folks, just keep on the back burner, like, are they on a beta blocker? Because, you know, if they're a beta block, then, you know, their heart rate isn't going to be as high as what you would expect. A 29-year-old, he got sweats in his week. He's pale. He's like muscle wasting. Should you suspect sepsis in this one? So based on vitals, like what you're going to have in the field, this is only 1 of 4 SIRS, right? Because you guys only have the ability to kind of identify the 3 of them. So the heart rate of 91 is 1. But then later, you know, we'll get the labs and it'll show the white count of 33. So technically, you know, this does meet, you know, SIRS with an unknown source of the infection. The big thing, and the reason why I put this on, is because any chemo patient, you've got to consider them immunocompromised. So if this was a younger, healthy person that was like, you know, pale and their heart rate was 91, you don't really need to like jump straight to sepsis there, but always think about it in these chemo patients, because obviously their immune system is going to be blunted just from that alone. 71-year-old, altered, hallucinating. Would you consider sepsis in this guy? So yeah, you'd have to consider it in this one. You know, UTIs in the older folks, especially, you know, when we have kids, they can't really tell us what's going on, and they can't say, you know, classically, I'm having dysuria and I've got pain right where my bladder is. Some of these folks, their presenting symptom would be confusion, you know, altered mental status, and then of course, if he's peeing on himself, that's cause for concern. 52-year-old with asthma, she's having vomiting, she's uncomfortable, but she's otherwise okay. Here are her vitals. Should you think about sepsis? There's a running theme here, and the answer is yes. And so she's got the respiratory rate, her temperature is low. So remember, it's not always just a high temperature, it's also a lower temperature as well. And the thing with that, the reason I put this one up is because steroid use. So another question that I would ask is, do you take any steroids? So, you know, are you on any chemo? Are you a transplant patient? You know, because those folks are we class them as immunocompromised. Are you on any steroid use? And this isn't like, oh yeah, I take, you know, Advair Discus. It's like systemic high dose steroids. So you'll see it in the COPD asthma patients. These rheumatic patients who have like lupus and sarcoidosis, they'll be on, you know, like 60 milligrams of prednisone every day, which is ridiculous, but necessary at times. And you've got to think about those folks as immunocompromised as well. So they're all kind of the important one. So the big takeaways from this is sepsis is everywhere. It's gnarly, it's expensive, it has poor outcomes. We use SIRS in the hospital in order to kind of guide our treatment options. And you guys are imperative. You see a lot of these folks before we even get to them, having the ability to just get access and start some fluids running. You don't have to pound the 30 cc's per kilo in, but just like recognizing it and being able to start the bag. And, you know, when they come in, then we'll talk about randomizing them, getting them on those good cultures, those good antibiotics after we've pulled the cultures. So yeah, does anybody have questions?
Yeah, so we had a couple come in, and my overhead things aren't working, so you might have to kind of explain the question. But the question is, what's our absolute contraindications for fluid bolus if we suspect sepsis?
So the question was, what are the contraindications to giving a fluid bolus? So some of my reasons for caution is you don't have to give the full liter, even if you give like a little 250 cc bolus, but I always check everybody's legs. I don't care what they came in for while they're talking to me. I'll just check their legs. I'll push on it. I'll see if they've got any edema. That makes me think that they're not handling or they're not mobilizing the fluid as well. So everybody just get in the habit of touching everybody's legs. If you're listening to their lungs and they're junky, crackly, and they're having issues with hypoxia, be cautious with those folks. Just because, you know, my suspicion is that if they have the crackles and they are having respiratory distress or hypoxia, then, you know, they're getting fluid on their lungs. I don't know if everybody knows about the knuckle test. So this is going to make me look, I'm really glad that we don't have high definition cameras right now, because you're going to see how dehydrated I am. But you can check, you just pinch the back of the knuckle there, and if it stays up exactly like this, control, the dehydrated, they need to drink more. Usually, you know, if you pinch it and it kind of goes down pretty quick, they're well hydrated. That's just like a poor man's test, you know, to check for skin tenting. I see Julie Brown. You know, whoa, I'm dehydrated. Everybody gets a liter in this room.
So, bad news, we definitely do have high definition cameras.
Oh, well, I'm not coming back next year. So yeah, Dialysis patients, they have issues, so just checking them. You can have a look in the back of them in the mouth, see how much it looks like the Sahara Desert, or do they have wet mucous membranes? These are just kind of, physical exam findings that would lead you to be like, well, I probably can hold on fluids for them, or it makes it, anything that makes you uncomfortable, just hold. I'd hate for them to decompensate in the back of the unit. So
I would say if they have signs of pulmonary edema, gross pulmonary edema, they can't manage their airway, those guys don't need fluids. Most anybody else will probably take a little bit for the most part. So it's risk to benefit. So if you think they're septic, they're tachycardic, they're hypotensive, and they're not sitting upright gurgling, give them some fluids. If they start gurgling, you gave them too much, stop the fluids, then sit them upright, right? But you got to be pretty aggressive with this. You mentioned the mortality rate of sepsis is 15%, right? So that's 15%. What's the mortality rate for COVID? Anybody know?
Way low.
Yeah, way lower. So it's about almost it's like almost 2%, like 1.7% in the US. In Mexico, I think it's the highest, and it's almost 8%. And look at sepsis, it's 15%. And we have ways to treat sepsis. So if we have someone who's septic and we recognize it early, we can be aggressive with those guys. But COVID is basically airway management, and hopefully they get better, right? So we got to recognize the sepsis and treat those folks. So if you think someone's septic and they have signs they're decompensating, give them fluids. If the fluids don't work and you have a long transport, consider pressors. And everybody has two choices. What are the two choices of pressors we got in the field?
Doesn't mean nothing.
Vasopressin. Yeah, not many folks carry vasopressin anymore, to my knowledge. So you got epi and you got dopamine, right? So dopamine is old school. In the ER, we don't use it for almost anything anymore except maybe bradycardia that's symptomatic, or somebody who's post defib arrest and got AEIOU, and now bradycardia will use dopamine. But dopamine will work. It'll buy you time to get to the hospital. The only thing you have is epi. You can make microdose or push dose epi, or you can start an infusion. Do not give epi 1 to 10,000 IV push, because then you're going to change the problem and it goes from sepsis to cardiac arrest. So that's not good. But if they're sick and symptomatic, they get fluids.
So what about a patient who appears sepsis that is in chronic renal failure, for example, because you see their dialysis fistulas?
You can, so again, it's about checking the physical exam, just the basic physical exam findings. Again, so the pretibial edema, you can check for skin tenting, look in their mouth, listen to their lungs, ask them when they dialyze. So a lot of these folks are Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday, and they'll tell you, they'll be like, oh yeah, I dialyzed yesterday, I completed the full thing. So, those folks aren't going to classically be as volume overloaded as my transport didn't arrive for the past week and a half, so I haven't been in, 6 days or however many days. And you'll see it, like these patients aren't discreet in them being volume overloaded. Like when they get volume overloaded, it goes on fast. So it's not subtle, like you'll be able to see it.
And again, it goes back to whether sick or not. So if I got a dialysis patient that I think is septic or hypotensive tachycardic, they're gonna get fluids. If they start gurgling, I'm gonna sit them up and probably they can get airway and do positive pressure ventilation, and we can dialyze them. It's risk to benefit. Don't withhold stuff just because they may get overloaded if they're symptomatic.
And specifically for the renal folks, so, when we talked about the urine infection, the pulmonary infection, the skin infection is a big one for those. I would get in the habit as well, aside from just checking the legs, is look at the graft, because these folks get access pretty frequently, and they're at a risk for getting infection of the graft itself. So just taking a look, put your hand over it, seeing how hot it is, looking for any redness. Do they have frank pus coming from the graft site? Because we see that also at the department. Another kind of, that's specifically for the kidney folks, is check the graft, because they get infected there a lot. So
So would you say that UTI is a very common cause of sepsis?
Yes, without a doubt. Yeah, I sure do.
So somebody just texted me, said, looks like I'm giving a liter of fluid to every nursing home transport.
So the question is, he ain't wrong. So as Ferg was saying, sick or not sick. So if I have the flu and I have a heart rate, 101, I got a temperature of 100.5, am I septic? By definition, I am sepsis, but looking at me, I'm immunocompetent. My body is handling the infection. I'm not showing any kinds of end organ damage. So, keeping hydrated is a good idea for me, but it doesn't mean we need to flood me and do cultures. And I mean, if you have pink eye and go for a run, some people would be like, well, technically, could that be sepsis? Well, yeah, I mean, I can't say that my heart rate, of 120 and my respiratory rate of 28 isn't because of my pink eye, but probably the fact that, I mean, I probably only ran like 200 yards because I'm out of shape, but, it's also, there's a bit of kind of common sense in it as well. Definitely the nursing home folks, they are a particular breed though, because they come in altered with the UTIs, with the pneumonias. A lot of those guys aren't mobilizing as well. So, they have the pressure ulcers. So they definitely also high risk for sepsis.
It's all about risk stratification, like we talk about with chest pain. So just because our protocol talk about you get a 12 lead on chest pain patients, we also get them on old people with nausea or weakness or diaphoresis. So like sepsis, you have to look for it, think about it. So if you have an 18-year-old healthy military person who's sweaty and fever and tachycardic, they probably, even if they did get sepsis, would do fairly well with it. Versus anyone in a nursing home, that's a hint they're probably unhealthy. They probably don't eat well. They're going to be dehydrated at baseline. So it's all about risk stratification. So think about your patient. If they appear ill and you're thinking sepsis, ask the appropriate questions. Do you have health issues? What would be a big health problem that would make people prone to sepsis? You, sir. Oh, God, it's a white shirt, man. So maybe somebody who has diabetes, they're high risk, right? So if they're diabetic and now hypertensive and tachycardic, they look ill. Obviously, you get your 12 lead because that could be something cardiac, but then you think sepsis as well. So ask those questions and then look for the sepsis. So if they're ill appearing, you get them naked. You cut their clothes off. You look for things that kill people. Look for trauma, you look for skin infections, things like that. Look for wounds or bed sores or a rotten off toe, something like that. If they're not diabetic, but they're now febrile, tachycardic, hypotensive, and they're older and have belly pain, then you start thinking about, is it an abdominal source? So what would make them high risk for that? Older people who had previous surgeries, diverticulitis, okay? If you think about folks that are high risk for infection in the bloodstream, those are people who have indwelling parts in them. So dialysis, people with central lines or ports for chemotherapy, all right, things like that. So when you ask your questions, your history, you're trying to determine if your patient's sick or not sick and what could be causing the problem.
Good.
Cool. And I would also argue, we talk about, for medical emergencies, we talk about, we stay on scene and manage them. For cardiac arrest, for respiratory, for CHF, we stabilize before we start moving. I would say, argue that sepsis is one of those things that you really can't treat too well in the field because we got to think about good IV pressure support and think about antibiotics. So if you got that diabetic who has a foot that is black and smelly and now hypertensive and tachycardic, you recognize sepsis, you start your line, you're doing your appropriate ABCs, you start your fluids, you start heading to the hospital so we can give them antibiotics or start that norepinephrine or medication if needed.
Very good. Thank you, Dr. Rose. I think that's all the questions we have unless anybody in the room has anything additionally. And we're going to take about a 10-minute break.
We're
gonna get started back
I'm gonna be the only one sitting
with Dr. Miller.
yelling at kids.
Yeah, turn it on. Got green light.
Green light.
All right, welcome Dr. Miller. She's gonna be talking to us about renal emergencies.
Okay. So I'm Bree Miller. I'm one of the PGY2s, actually a 2, at UAB, and we're going to talk about renal emergencies. We're going to talk about a little bit about the pathophysiology of end-stage and chronic kidney disease, and we're going to talk about the complications that y'all are going to see pretty frequently and talk about what we can do for these folks. I have nothing to disclose. I got these slides from Dr. Ferguson, and a lot of the photos I kept in because I didn't quite understand the relevance. So if you have questions about any of the images, please direct that feedback to Dr. Ferguson.
Yeah.
So the kidney is kind of a little bit magic, and I don't have a British accent, so that's 2 strikes against me. But we'll try to get through this. Oh, I know.
Can you make one?
No, sir. I cannot fake one. No, I think that would be offensive to every British person. So your kidneys can do a lot of cool stuff. They keep your body in homeostasis, which is kind of a fancy way of saying that keeps everything in your body in equilibrium, keeps everything balanced. So that's looking at your acid-base status, all of your electrolytes, your blood pressure, and your volume status. And it also helps secrete urea and gets toxins out of your body. So your kidneys are super important. We are not going to walk through how all of this works because I went through it in medical school and I still don't fully understand all of it. So essentially, your blood comes through your kidney, okay? Your kidney reabsorbs a lot of the fluid from the blood, water and your electrolytes and all these toxins move in and out of the kidney while your kidney decides which ones it needs to keep and which ones it needs to get rid of. And then it excretes urine. And your kidneys also auto-regulate, which is this really cool thing where they keep their function the same regardless of what your blood pressure is. So again, it's a lot of magic. This is just saying all that in a different way. Your kidneys really regulate everything in your blood. So if any of that is off, then if your kidneys are not working correctly, then your electrolytes are going to be off, your blood volume status is going to be abnormal, your pH is going to be abnormal, and you can't get rid of dangerous stuff in your body. Just a quick review of your anatomy. Your blood flows into your kidneys here, moves through them, then your urine gets excreted out through your ureters. You have 2 of them going down here until the urine is stored in your bladder, where ideally it is stored until a socially appropriate time to urinate through your urethra.
Roll Tide.
Yep. In an ideal world. And this is just some more photos of your beans. So there are a couple different causes of your kidneys not working correctly. And we really break it down into 3 different parts. Pre-renal, meaning happening before blood gets to the kidney. Intrinsic, meaning problems with the actual kidney. Or post-renal, which is problems after urine leaves the kidney. So the first is pre-renal, and this is the most common type of kidney injury. This happens, the easiest way to think about it is anything that keeps blood from getting to the kidney. So if you're super dehydrated, if you're septic, like Amy was talking about earlier, if your doctor gave you too much diuretic and you have lost a lot of volume from that, if you've taken too much of your blood pressure medicine and your blood pressure is 60/40, you're not getting enough blood to your kidneys and they're not going to like that. Or blood loss can also cause it. I like that. That took a while. All right. You also have intrinsic causes of kidney failure, which are problems within the actual kidney itself that affects that nephron we kind of skipped over earlier. So you can have, within the kidney. You can have infections, so a really bad UTI can cause damage in the kidney. Autoimmune diseases like lupus, but also some less common ones like Goodpasture syndrome, IgA nephropathy. If your patient tells you that they have that, they probably know that it can cause kidney damage. High blood pressure and diabetes are huge causes of intrinsic kidney failure, and that's probably what most people that y'all will pick up who are on dialysis already, that's probably the reason they got there, not always. You can have trauma to the actual kidney that's going to cause your pre-renal injury with the blood loss, but also if the bullet hits the kidney, obviously then it's not going to function correctly. And then medications can cause intrinsic kidney failure. So especially certain types of antibiotics, NSAIDs like ibuprofen, certain gout drugs, certain seizure medications, diuretics, PPIs people take for acid reflux, and then contrast dye, which we give them in the hospital. And then you've got your post-renal causes of kidney failure. So these tend to be obstructions. So think about if you step on a garden hose and water backs up behind it, that's kind of what happens here. So if you're blocking your urethra with your big prostate, or if you have a big stone blocking your ureter, all of the stuff builds up behind that and it causes damage to the kidney. Your risk factors for renal disease, kind of like what we talked about, it's pretty intuitive if you just think about what we just went through. So different medications, substance use, contrast dye, systemic diseases that most of our Alabama patients already have, and then antibiotics. And then again, you can direct your feedback to Dr. Ferguson for this. When patients get to the hospital, they typically get labs. Again, this is not something I'll be doing in the back of a unit, but just kind of what we're thinking about when we get there. We look at how all of our electrolytes are balanced. We particularly care about their potassium because that can kill you really quickly if it gets super abnormal. And then we're looking at their creatinine, which is a measure of kidney and protein function. So that's the kind of the normal range for it. So in acute kidney injury, you have, like the name says, a kidney injury that happened quickly. And typically these can be reversible. Like we talked about before, pre-renal is the most common cause. So someone comes in super septic, not perfusing their kidneys well. That's probably the most common reason we see, versus intrinsic is about 20% of them and post-renal is about 10%. We also do this to people in the hospital, especially if we give them a lot of diuretic or from antibiotics. And the interventions that we do kind of depend on what caused the injury. So if it's a pre-renal injury, you just want to increase your blood flow to the kidney. So y'all are doing that on the truck by starting fluids, getting that going. If it's an intrinsic issue, you have to correct the underlying cause and avoid further nephrotoxins. So stop giving them diuretics if that's the issue. And then if it's post-obstructive, you need to relieve the obstruction. So you're going to be doing your physical exam, assessing their volume status. We just went through how to do that. So you're looking at for peripheral edema, you're looking at their mucous membranes, you're listening to their lungs, you're watching their breathing. Do they look like they're really struggling? And then when they get to the hospital, they'll also get labs and imaging. We're particularly looking at that value called the creatinine, and also the GFR, which is the glomerular filtration rate. It's a measure of how fast or how well the blood is moving through the kidney. And then you're also looking at your 12 lead for signs of hyperkalemia, which we'll talk about in just a moment. You're resuscitating them if that's what they need. You're thinking, do they need blood or do they just need fluid? You're treating the underlying cause and you're not giving them anything to make it worse. Like we talked about earlier, you're assessing your volume status before you're just flooding them with fluids. Some people you want to be kind of gentle with, especially these ESRD people. But if they're hypotensive, if they look sick, you're probably not going to be wrong. And then chronic kidney disease is not reversible. And like I talked about, a lot of our patients probably got it from diabetes, high blood pressure, or from these autoimmune diseases, chronic medication use. And then ESRD, or end-stage renal disease, is the loss of renal function to the point where their kidneys are really just not functioning at all. And these are the folks that end up on dialysis or some kind of renal transplant. I thought this is kind of impressive. 50% of people who are started on dialysis will die within 3 years of starting therapy. So these people are sick. If you just pick up someone from a nursing home and they're a dialysis patient, they're already sick before whatever the call was for. So these are people that need your close attention. So the reasons that ESRD are bad for your body, your kidneys can't excrete toxins like urea. When the urea builds up, it can cause symptoms of encephalopathy, dementia, peripheral nephropathy. So these ESRD patients that present really, really confused and haven't dialyzed in a week, they could just have a huge amount of urea in their system. These are your other features of urea and acute cat that Ferg had in his initial slides. So these people are real sleepy, real confused, and they can eventually go into a coma, lose their airway. CKD can also cause heart problems, so coronary artery disease, heart failure, high blood pressure, pericarditis. You can get an immunodeficiency because you're not able to produce all of the factors that your immune system needs to work correctly. And these people tend to be pretty anemic too, because your kidneys produce something called erythropoietin, which helps you make new blood cells. So these people are at risk of pretty bad anemia, and their kidneys are also not making a lot of vitamin D, which helps with your immune system. They're at high risk for GI bleeds, which is not great, especially if they're already anemic. And then they have brittle bones because, like we said, they have the decreased vitamin D, decreased calcium. They're not able to reabsorb it very well. So these people are at risk for broken bones. Indications for urgent dialysis. I think the most common mnemonic for this is AEIOU. So the A stands for bad acidosis. So that's if their pH is less than 7.1 and isn't responding to any of our therapies. That would be an indication to take them directly to dialysis. If they have an electrolyte abnormality, so potassium is the one that we think about the most. If it's above 6.5 and it's not coming down, they're at risk for really bad cardiac arrhythmias. So that would be a reason to take them right away. Certain medications are dialysable, so your toxic alcohols, your aspirin, your lithium, your barbiturates, those can be reasons to take someone straight to dialysis. Volume overload is a common one we see, and so these are your people who are on BiPAP, not doing well, about to get intubated. You can't give them diuretics because they don't make urine anymore, and so they just need some way to get the fluid off quickly. And then, like we talked about, symptomatic uremia. So if they have associated pericarditis or if they're very, very altered, that would be a reason to take them quickly to dialysis. So there's two major ways people get dialysis as an outpatient. One is hemodialysis, where the blood is taken out of their body through a graft or a fistula or a line and filtered through a dialysis machine, which acts like a kidney outside of the body and is then returned to them. And then the other one is peritoneal dialysis. That's where they have a port in their abdomen and they can dialyze at home by they put a special kind of solution into their abdomen, and their own peritoneal membrane kind of filters their blood, and that can be done daily. So hemodialysis is more common, and it's the one that can be done emergently. You'll see some people who have these kind of semi-permanent catheters put in. A lot of them are tunneled with IR. These are the fastest way to get someone to dialysis, but they're only good for the short term because they're a huge risk of infection. So if you see someone with one of these, you're going to want to look at where it goes in. If it's big and red all around it, that's when you're thinking about sepsis, like we talked about earlier. And they can also claw off, which is not ideal. More long-term, you'll see people with fistulas, and these people have a special surgery that connects their vein and artery, usually in the arm. But it takes weeks or months before it's ready to be used. So a lot of times people who are approaching ESRD will go ahead and have these put in before they actually need them to let them mature. And then these are the arms that we're not getting blood pressures on. You're not sticking on this side because we don't want to risk messing up this fistula because it's life-saving for them. This is just another photo of kind of how they're going to look when you pick them up. I'm sure everyone's seen them at this point. Grafts are really similar to fistulas, except instead of connecting the vein and the artery directly, they put a tiny little bit of tubing in the arm to connect them. And they function very similarly. These are a little bit higher risk of infection. When you pick these people up, you're going to want to know why they're on ESRD, when did they last dialyze, what's their normal dry weight, and typically these patients will know, and they'll know if they're over that weight. And then you're going to want to assess what kind of vascular access they have, and it's also good to know if they make urine or not. So the complications you're going to see from this, that's like what Amy was saying. It's really important to look at the graft or whatever site that they dialyze through, because they can get really bad erosions. They can get aneurysms from the repeated punctures. And then probably the most dramatic one is going to be if they have hemorrhage from the vascular access. So this is going to look kind of like an arterial bleed, because if you think about it, the artery is right there connected to the vein. It's going to be a high pressure system. These things can someone can bleed out really quickly from this. These are actually very, very dangerous. So the first thing you're going to want to do is get their arm up above the level of the heart to try to stop the bleed as well as you can. And really what they need is pressure. So you can hold it down for 5 or 10 minutes, and it's going to have to be pretty good pressure. If you have quick clot or combat gauze with you, you can put that on. Well, that's usually what we'll start with at the hospital. In a life-threatening scenario, you can put on a tourniquet. Obviously, this is not ideal in the same way that we don't like blood pressures on that arm because you risk messing up the graft. But if it's that or the patient's bleeding out and dying, then that would obviously be indicated then. And then they're going to need to be transported to a hospital that has vascular surgery access. So this is not someone that needs to go just to a tiny hospital. And then peritoneal dialysis works like how we talked about before. You inject diastole into the abdomen and it can drain out. These patients are usually pretty good about doing this at home, and they put a couple liters in, leave it for a few hours, and then let it drain out. Their biggest complication is going to be infection or peritonitis. So this is what normal peritoneal dialysate looks like, and then this is cloudy. That would be concerning for infection, and that's typically why they'll call and for transport. They'll have fevers, they'll have bad belly pain, their belly will be really tender, and these people can get really sick. And you ask them similar questions to what you're asking the hemodialysis patients. Do you make urine? Did you dialyze today? Have you been having fevers at home? During dialysis, there's several different complications that can happen. They can get hypotensive, especially if the center's pulling off fluid really aggressively or too fast. And they can also have something called disequilibrium, which is where fluid shifts in between the blood and the brain cause cerebral edema. And so these people get really nauseous, they'll be confused, they can actually have seizures and go into comas from this, so it's really dangerous. So the solution when this happens at the dialysis center is to stop dialysis, first of all, and then give mannitol to decrease the intracerebral pressure. You can also get air embolisms from it, causing strokes. You can get bad electrolyte abnormalities, again, from all the fluid shifting. You can get hyperkalemia, hypercalcemia, hyponatremia, and then hypoglycemia we're all aware of. So this is your patient. He's a 56-year-old guy with ESRD, hasn't dialyzed in several days. He did some cocaine at home, and now he's short of breath. So what is abnormal about his vitals?
Other than cocaine?
Other than the cocaine use, yeah. Oh, yeah, so he's bradycardic. Looks like he's in some sort of respiratory distress. He's breathing fast. His stat is not great. He's pretty hypertensive. He looks volume overloaded, so really none of that is normal. So what do you want to know? What do you want to do? Great, yes, okay.
CPAP, oxygen.
Yes, agreed. So CPAP, oxygen, airway is first. I like the CPAP because he's crackly, he looks volume overloaded, he's hypertensive. It's probably pretty safe to say his lungs are not dry. So you can start with oxygen. If that helps, great. If that's not helping, he needs the positive pressure. And then I want to see his EKG because he's bradycardic. So this is what it looks like. Is this normal or no? Ugly. I agree. This is an ugly EKG. So it's real wide. Your T waves are real big. I don't see P waves really. I guess you can kind of be convinced that it's here. So not great.
He does have a pulse, right?
He does, yes. He has a pulse. It is bounding. He's talking to you. He's agitated. Probably doesn't need ketamine yet. So he is probably pretty hyperkalemic with that EKG. And so what you'll see with hyperkalemia on EKG is first your PR interval gets long and then your T waves get real tall and pointy as your potassium goes up. And then as your potassium keeps going up, your P wave flattens out and your QRS gets really wide. So that's kind of where we are here. You've got real flat P waves if they're even there. Your QRS is super wide. Your T waves are super peaked. And then at some point they go into a sine wave and then they sometimes don't have a pulse. So the way you want to treat that is kind of in 3 steps. First, you want to stabilize the cardiac membrane. That's the most important. And you're going to do that with calcium. You want to give an amp or a gram IV over 2 to 5 minutes, and that can actually be repeated after 5 minutes if you don't see a response. It only lasts 30 to 60 minutes, so if you're on a long transport and you're really worried about this, you may need to redose them after an hour. You can use calcium chloride or calcium gluconate. Calcium chloride can cause really bad necrosis if it extravasates at all, so we really only use it through a central line or if the patient's actively coding. So we'll use calcium gluconate much more often. And remember, the calcium doesn't lower your potassium at all. It just stabilizes your cardiac membrane so you don't go into these deadly arrhythmias. And then you want to think about shifting the potassium from the bloodstream into the cells. So you can use insulin. Anytime you're giving these people insulin, you want to give them glucose because you're not giving the insulin for hyperglycemia. You're giving it for something else. So you can really drop their sugar fast. So if their glucose is less than like 250, I would give it your insulin with an amp of D52. So you're going to give 5 to 10 units of insulin, of regular insulin IV for this, and it lasts for 4 to 6 hours. You can also give albuterol, and that will push the potassium into the cells. It doesn't work in about 40% of the population, and it's probably less effective for your patients who are taking beta blockers. So the insulin is really going to be your best bet. And then there's a classic teaching about giving bicarb for this as well, but it's pretty questionable as to whether or not that actually works, especially in people whose pH are normal, so they don't recommend that anymore. And remember, this also doesn't really get rid of potassium, it just gets it out of the bloodstream back into the cells. So what you really want to do, the ultimate treatment, is removing the calcium. And we can do that through the GI tract with Lokelma or K-exolate. These are potassium binders that bind potassium in the gut and essentially give you this life-saving diarrhea. And if the patient still makes urine, you can give them Lasix. But for a lot of these people, they don't make any urine, so Lasix isn't going to help at all. And then obviously dialysis is the definitive way to get potassium out. So that's really all I have. I want to say thank you to all the EMS units tuning in. I know it's been a tough year and we really appreciate y'all. And I think sometimes when y'all bring sick patients in, we don't do a great job of stopping and saying thank you, and this was great. But you're very appreciated from our end, and I can take questions.
Yep, so everything I've gotten so far is on the same subject, and it's not really, doesn't have anything to do with your lecture. The subject is, hey, can I access those dialysis things during an emergency? And so we always get mixed answers to that question. And then the follow-up question to that is, how do I access those dialysis things in an emergency?
I'll go, sorry.
I would defer to Dr. Ferguson. I would say they'd probably have to be pretty dead.
Thing they're talking about. So if you're talking about a cortex or graft, if the patient is dying, coding, and you have no other access and you can't drill them, sure, why not? Because they're in cardiac arrest and you need access, right? The reason you don't just randomly access those things is because if you screw that up, they can't get dialysis. And if they have one of those grafts or fistulas, that's probably a sign they've had numerous central lines in, and it's going to be tough to get a central line in to get them dialysis. So if they're dying in front of you and you have no access, sure. Otherwise, no. Now, if it's a central line, like she showed earlier, those can be accessed like any IV. So you can unscrew the cap, put your fluids on there, and run with it. But again, I'd only use it if there's no other options. And with the easy IOs that we have these days, you can probably get access in most people. But again, it's like anything else to do, risk the benefit.
Very good.
So she mentioned peritonitis for those folks who get peritoneal dialysis. What's the mortality rate for peritonitis? Anybody know?
Probably pretty high.
I got one comment. Good, thank you, doctors, for answering. I appreciate it. Very good. Great. I got like 6 doctors in the room and everybody just stares at me. I think, yeah, man, great. Yes, I would say pretty high. So they say for spontaneous peritonitis, where just somebody just randomly gets an infection from leakage out of the gut or something, it's like 5%. For others, it's up to 75%. That's pretty freaking crazy. So people who do peritoneal dialysis, if they're septic, your brain should be thinking that source is probably their gut. And that's a big mortality rate. Those folks die pretty quick. So they need aggressive resuscitation, they need early antibiotics, and that's not somebody you stay on scene and play with, you get them moving to the hospital. That's pretty impressive numbers.
So the folks that have the retroperitoneal dialysis, do they have a lot of those boxes of fluids in their home generally, or how would we know they're on dialysis if they're not conscious and talking to us?
They should have boxes of fluids in their house. The other thing is, y'all remember when the state did the last protocol update, they had a dialysis disconnect. People are doing hemodialysis at home now as well. So I would review those pictures. It's not complicated, but if somebody, you get on scene and they're hooked up to dialysis and they're sick and you're working them, you gotta move them. You gotta know how to clamp that off and work it. It's not complicated, but you don't be Googling it at 2 o'clock in the morning in between bouts of a lupus going on and off.
The other way you'll know they're on peritoneal dialysis is they'll have a port in their belly that they can move it in and out of.
That's a helpful sign.
Yes, that is a red flag. Yes, a tube in the belly, abnormal.
So we had another question about bleeding dialysis fistulas. So this is something that's come up in my career a couple of times. It's not an uncommon call for EMS to go to a dialysis center where staff at the dialysis center has been trying to control bleeding from a fistula for a long time before we're called. And the message from dialysis center staff, in my experience, is very consistent. Don't do anything that harms the fistula at all costs. Yet if they're bleeding and we can't control the pressure, we think about tourniquets. Any thoughts on that process?
So I think if you're concerned that they're about to die from blood loss, I would go ahead and tourniquet it. And it's like we've talked about with the other stuff, it's risk benefit, looking at, can we get this patient to the hospital? Are they hypotensive? Are they tachycardic to like the 140s because they're bleeding so much? You know, are they completely soaked with blood and you're concerned that they could code soon from blood loss? That would be a reason to tourniquet it. But if they're relatively stable and they're just bleeding a lot and making a mess, I would continue to just hold pressure.
Dialysis centers have clamps.
Yes, we've actually had a couple of cases that I'm aware of over the years in this region of the clamps failing to work and the patient being so anticoagulated that they bleed for an extended period of time, actually having a death from hemorrhage from lack of tourniquet use. So that's obviously the worst outcome that we could achieve. I would suggest, and I'd love to hear the comments from the physicians, I would suggest if they got active bleeding and an altered mental status, it's probably time to use a tourniquet.
I would probably hold unless there's signs of like hemodynamic instability on top of that as well. Like if they're acting real wacky, but they're also like super hypotensive and they're tackling in the 130s and 140s and, you know, they're clammy and pale and, you know, if they're just like altered, unresponsive is different, but if they're just altered and acting kind of wacky, I mean, that could be really another thing, you know, the uremia that she talked about, so I wouldn't like quick to tourniquet it.
Another important thing is these grafts and fistulas need very directed pressure. If you take an abdominal pad or some sort of trauma bandage and you're applying like very spread out pressure, that's like not providing very good pressure control to the actual fistula. Like 1 finger, 2 finger, 3 fingers right on the fistula itself, very direct pressure to the source. Because if you've got a big bulky dressing in between your hand and the pressure, that pressure is not very, it's very like spread out across like a large area of skin. So it's not nearly as much as very direct pressure by 1 or 2 fingers.
I agree. I think we're used to seeing the clamps that the dialysis centers use. As I just had another person comment, what about the use of quick lock? Is that a better choice than tourniquet?
Yes.
For bleeding dialysis side? Yes, the consensus is yes, that is.
I think it depends on what's going on. So if they're sitting there and you got pulsatile flow coming out of that, you know, you get hands on immediately. And if they look ill, yeah, throw a tourniquet on there and crank it down. If it takes a few minutes to find the tourniquet out of your junk bag, then yeah, put the quick clot on there, hold direct pressure. But a tourniquet will stop that. And if somebody has a true rupture of a fistula or a graft, it's gonna bleed like freaking crazy. And you're gonna need a tourniquet pretty quick. And remember, folks on dialysis, they get a blood thinner, they get heparin before they get dialysis. So they're gonna be anticoagulated-ish, right? The other thing is, she talked about, these guys are anemic at baseline. So they don't start off with a full tank of blood to begin with. So a couple of minutes of squirting and they're gonna be in a bad shape. You mentioned altered mental status with this. What would be another cause for altered mental status in a dialysis patient? They're sitting there, hypoglycemia. That's all the freaking time. So always think of that as well. But if they're bleeding from a tourniquet, yeah, direct pressure, hands on deck, fingers, combat gauze. If you got TXA, want to put it on a 4x4, shove it in there, that's fine. If that's not working, put a tourniquet. But remember, tourniquets go high and tight, right? What if they have a graft in their groin, right? So they got a loop graft in their groin for dialysis, and that thing starts to bleed. What can you do for that? High in the groin.
Quick clot, outflow diesel.
Yeah, quick clot, direct pressure, and start moving. Yeah, drop your knee in their groins, do something for direct pressure. Those are scary. They're scary for us as docs because if somebody has a graft in their freaking thigh, that means we run out of other spaces. So again, accessing this person is going to be a nightmare.
So what, we seem to have, and I don't know the numbers, but we seem to have a lot of dialysis patients in the Birmingham area. Would you say that we have more dialysis patients or chronic renal failure patients in this population center than is normal, or is this about average? Got any idea? And what are the common, what causes people to get to that point typically?
So I can't quote the national numbers. I would imagine we have more dialysis patients here because for the same reason that we have more hypertension, more diabetes, more, cardiac disease here as anywhere else, because it's all the same risk factors, right? So chronic uncontrolled high blood pressure, chronic uncontrolled diabetes are probably the two most common reasons that our patients end up on dialysis. You have your other ones, your autoimmune diseases, the more rare ones. But I think it's the same reason that we have a higher incidence of heart disease here than other places in the country. It's just our patient population is just sicker to begin with.
Yeah, we're unhealthy.
Yeah.
We're in the septic belt. If you look at the data, we're also the diabetes belt, the obesity belt, I smoke too much crack belt, all those belts. So a lot of high risk. All those. Sure, dude. What'd you say?
He said you're judging.
Oh, sorry, yes. I wear some of those belts too.
No, yeah.
Not the crack.
Everybody got at least one
No,
of those.
not the crack. I don't
Not the crack one, yeah.
Not the crack, but I wear on the belts. She mentioned the use of albuterol for hyperkalemia. I think, even though it doesn't work with all people, it's still reasonable. There's no risk to giving somebody who's hyperkalemic albuterol. And if you don't have IV access and you got to find your drill to give them the calcium, it's quick and it's easy. What's the dose? Anybody know the dose? In the doctor, the dose that we give? How much?
5 milligrams.
Say more than that. I think it's 20. Yeah, so for hyperkalemia, I'm gonna give 4 or 5 times the normal dose. In the field, if you're carrying the dual nibs, the ipratropium bromide, albuterol, you can give 5 of those. It's not gonna hurt anybody to give them extra ipratropium bromide. Not gonna do a lot of good, but it doesn't hurt them. So, state says you can carry albuterol or the dual nibs. If you carry dual nibs, I would open up 5 of those, squirt it in your nebulizer, stick it on the face, crank it up. As you're looking for IV access or IO access to give them that calcium. I think most folks carry calcium chloride, not gluconate, so that's reasonable if you have it. If you have the gluconate, great. If you don't, calcium chloride is fine. I like the fact you mentioned the sodium bicarb. So the docs in the room, who gives sodium bicarb routinely for your hyperkalemia now? Well, yeah, the medicine docs, right? Yeah, I'm like you, I don't use it unless I know they're acidotic for some other reason. If it's just hyperkalemia, I usually don't give it. Now, if I got somebody that's in DKA, they're breathing 40 times a minute, their end-tidal CO2 is 6, and I know the acidotic is dirt, and I'm gonna have a transport, I'm gonna be hitting with a bunch of fluids, I'm gonna give them albuterol, and I may start a bicarb infusion. But like you said, I don't use a lot of bicarb. And the pathophysiology of pharmacology is way too confusing for my brain too, when you start thinking about it. But the current consensus in the ER is we don't give sodium bicarb pushes for hyperkalemia. When we think about dialysis, there's kind of two types. There's CRT, and then there's routine dialysis that we use in the hospital. Can anybody tell me the difference? Because I don't remember. I didn't say that out loud, did I?
CRT is continuous.
Okay.
You have less pressure changes.
So if we admit somebody to an ICU at UAB, for example, they're gonna get that CRT. They're not gonna get routine dialysis. It's tough to get that machine in there and manage that. So we'll do this CRT and just do dialysis continuously while in the unit to kind of work as an artificial kidney. Versus if we have somebody that comes in hyperkalemic, fluid volume overloaded, and we can get their hyperkalemia stabilized, get them on BiPAP, get them breathing better, we can get them off BiPAP and get them to routine dialysis, it's a lot better. Then they can get a couple of hours on that machine, get their fluid off, and it saves them an ICU trip and saves them a tube, which one is great for the patient, and two, I think Dr. Rose mentioned the cost of the ICU stay is unreal. It's like buying a brand new truck per day, so it's pretty expensive. Remember, folks who have kidney problems, they don't clear medicines as well. So it's really easy for those guys, if they're on a beta blocker or calcium channel blocker at baseline for hypertension, if their kidney function worsens, so they miss dialysis, those medicines can build up, they can get bradycardic, hypotensive from those things. So kidney issues are pretty bad.
Same with people, I had a couple people recently come in with like, they take an opiate at baseline, but then they also have like their acute chronic renal failure, and now they're altered because their morphine's not clearing.
Yeah, perfect. Yeah, so they just can't clear those drugs. Exactly. So very cool. So, yeah. What else you got, guys? We got a few minutes.
Well, we seem to be hung up on the bleeding issue, so the next question is, what about TXA? Yeah.
I think there's no risk to it. I think hemorrhage control is the mainstay. So finger in the hole, stop the bleeding, throw a tourniquet if that doesn't work. If they have signs of shock, then TXA is reasonable. It's category B right now if it's not traumatic hemorrhagic shock, but it's a reasonable thing to do. What they really need is hemorrhage control and then blood. We know they're gonna be anemic at baseline. They lose a little bit of blood, they probably can't tolerate it, so they need blood. Questions, other questions, comments?
That's all we got. I know, finished up a little early today, but hey, we really appreciate Dr. Miller, Dr. Rose. Great lectures today. Thanks, for everybody online. Everybody remember to fill out an attendance form. You can get it by emailing alabamaemschallenge@gmail.com or by clicking the link in the chat box. So Dr. Ferguson, what's our schedule coming up? September 22nd, we'll be in Oxford, Alabama at the Oxford Civic Center.
Yep.
And then in August, I'm not sure.
Not August.
I mean,
October.
October.
Yeah, ultramental
Yeah,
status.
alternate status. I should get a fluid bolus.
Right.
Immediately.
Yeah, and some ketamine.
And some ketamine.
Yeah.
Or coffee.
Yeah.
Or coffee, yeah, that works too.
Yeah, so we'll be at the Fire College the fourth Wednesday, and we'll have a skills lab that day. The second Wednesday, I'm assuming we'll be here at Center Point. We'll be at Brim's at some point soon. We're almost ready with the IT there. And then I think we're looking at going to Gadsden at near the end of the year, and then be up north, and then in Dothan, January, February-ish as well, so.
Awesome, got a lot of exciting things coming up with the EMS Challenge. Thanks, everybody, for participating, and we will see you next time.